In this video, we will learn how to determine if a radiographic image is optimal as far as exposure. In a previous video, our example had an overall exposure that was acceptable, but how can we tell if the exposure was acceptable? And shouldn't we be looking at our exposures to make sure that they're optimal or the best they can be? So there are indicators we can look for to tell if our exposure was optimal. The first is underexposure or quantum model, which, as we said before, shows as a grainy appearance on our image in the hardest to penetrate regions within the anatomy. So most likely the thickest parts being demonstrated on the radiograph. For example, this may be the thickest part of the bone or the thickest area of the abdomen. Overexposure is a little harder to see on an image because the computer compensates for it rather well. Gross overexposure, which usually doesn't show on an image until it's 8 to 12 times overexposed, shows as a flat black appearance on the image in areas that are easily penetrated. There is no detail in this area even when adjusting the window width and level. This shows up in areas like the lungs, soft tissue, and the thinnest parts of the bone. In this example radiograph, you can see that there is no information in the lung region. No change in the window width or level will bring this information back. The lung markings and the posterior ribs are saturated with too much information, meaning too many x-rays penetrated the tissue, and based on that information received, there is nothing attenuating or blocking the x-ray photons to provide a shade of gray. A saturated area like this contains no diagnostic information, and it must be repeated. This happens in digital imaging when the image receptor is grossly overexposed. For example, a kVp of 120 and a mass of 2 would be adequate to expose a PHS, but instead 120 kVp at 64 mass was used. This is way overexposed. Most overexposed images appear fine visually, so how can we tell if our exposure technique is optimal and adheres to ALARA or as low as reasonably achievable? Overexposing 3, 4, 5, or 6 times and the image looks fine doesn't sit well with me, and I hope it concerns you as well. I don't know any technologist that wants to overexpose patients, but it happens, so there has to be another way to let us know we are overexposing patients. The exposure index, or exposure indicator, and the deviation index, or DI, are computer-generated numbers that can indicate the amount of radiation reaching the image receptor for a particular projection. It is based on a histogram, or graph, of all the values of gray within the image. The computer evaluates the histogram and determines a number. Many factors affect the exposure index number and the DI number, other than the exposure techniques including collimation, artifacts, centering, and alignment. So here are some things to know about the exposure index. The EI is used in computed radiography or CR systems. The EI should be within an acceptable range determined by the radiologists interpreting images at that facility. They are the ones responsible for the images being of diagnostic quality, and they set the standard. Radiographers should aim for an exposure target within the range that requires the least amount of exposure to be within the acceptable range to avoid overexposure and to adhere to ALARA. Aiming for a target in the middle is easier and gives technologists more wiggle room for errors, but it is not the responsible or ethical thing to do. Technologists should challenge themselves to aim for the least amount of radiation needed to produce an optimal image. Radiographers must remember that the EI can be thrown off by a number of factors and cannot be the only determining factor for a repeat exposure. This is why technologists are taught to evaluate their images on indicators other than the EI as well. Next, let's look at the deviation index, or DI. The DI is used in direct digital radiography, or DDR. Radiographers should aim for a 0 on the DI scale to create an image that has an optimal exposure. The DI is the difference between the actual EI and the target EI and is the industry's way of standardizing exposures in the field across manufacturers. Radiographers must remember that since the EI can be thrown off by a number of factors and the DI is based on the DI cannot be the only determining factor for repeat exposures. Just as with EIs, the image needs to be evaluated properly for evidence of under and overexposure. So let's look at another example. Using a Kodak or Carestream computed radiography system, a radiograph is created using 92 kVp and 80 mass. The EI is 2143. We are assuming the image is visually fine and there are no indications of a skewed histogram. The acceptable range for the EI is 1700 to 2300 for this Kodak system. So what should we do? If a repeat is not needed for another reason, we would submit the image as is. However, if a repeat is warranted, we would want to adjust our exposure because the EI of 2413 is telling us that our abdomen was overexposed and our technique should be adjusted. The KVP is above the minimum, so we should leave this alone. It is where it needs to be, and we should adjust the mass instead to lower the patient dose and achieve an optimal exposure. So here we see the rules to adjust the index number for Kodak or Carestream CR. To increase the EI by 300, we double our exposure. To decrease the EI by 300, we cut our exposure in half. We know that we need to decrease the EI since it was too high, so we will be using the box on the right. Since we already said that we will modify the mass, we see that we can reduce the mass by 50%, and this will drop the EI by 300. So let's get back to our example. We had 92 kVp at 80 mass, resulting in an EI of 2413, which we determined was too high. So we can decrease the mass by half, and this results in an EI being decreased by 300. With this change, we now have an exposure technique of 92 kVp at 40 mass, resulting in an EI of 2113. Is this acceptable? The acceptable range of the system was 1700 to 2300, so this is acceptable. But is it optimal? So no, this would not be considered optimal. We can further reduce the overall exposure by again cutting the mass in half and decreasing the EI by 300. This now brings our technique to 92 kVp at 20 mass, resulting in an EI of 1813, and this is acceptable and closer to optimal. Remember, our goal is to use as little radiation as possible to produce an adequate image in order to adhere to ALARA. So let's take a moment to review. What are the rules to modify KVP? Remember, the 15% rule is used to adjust our KVP. An increase in 15% of the KVP will double the exposure, and a decrease of 15% in KVP will half the exposure. So what are the rules to modify mass? Doubling the mass will double the exposure, and halving the mass will cut the exposure in half. How does the radiographer determine if an exposure was optimal? So first we evaluate the image looking for signs for over and underexposure. We also evaluate the exposure index or EI or the deviation index or DI to make sure that the least amount of radiation necessary was used to make an adequate image. We also look for reasons the EI may be skewed. This may not be apparent right now, but it is something you will learn later on. I hope you found this information to be helpful. If you have any difficulties understanding these concepts, please seek additional instruction from one of the faculty. Knowledge of these concepts is essential to choosing proper technique selection in the clinical setting and protecting our patients from habitual overexposure, known in the field as dose creep.